Welcome again to today's Hope in the Pipeline podcast. And I'm privileged today to once again have as a guest Dr. David Weed, pediatrician. And today we're going to talk a little bit about his experiences with and my experiences with treatment of headaches in the pediatric population, which can include little kids and adolescents and teens. And we'll talk about it a little bit about how things might affect their parents as well. So we'll touch base on that. We'll try and touch base a little bit on what some of the symptoms of headaches are and how they affect people's lives, and talk about some of the older treatments and some of the newer treatments, and touch base on maybe some of the upcoming clinical trials and things that are being researched for treatment of headaches and to try and define the cause more specifically. So lots of things to be excited about today. And once again, welcome to Dr. Weed.
Thanks for inviting me on.
You bet. So I thought we'd start today with just asking you to talk a little bit about the impact of a variety of different types of headaches on your pediatric practice. Mm-hmm. And notice I didn't start with talking about the impact of headaches on the patient, right? We know it impacts them, but headaches are such a common thing. And so I know it has to take a lot of time and manpower within your practice to manage. And sometimes, obviously, people come in acutely with a headache right then and there. Yeah. So you've got to kind of stop and help. So anyway, if you want to tell us a little bit about that, and then we'll see where that leads us today.
Sure. Well, thanks again for having me on the podcast today.
Yeah, my pleasure. Yeah.
So we see headaches in the office in different ways or different presentations. We do see a fair amount of kids who come in with headaches right then. Both severe and relatively mild, but mainly more severe. We have kids come in to seek help with managing their headaches because they're occurring too frequently. They cause frequent school absence, frequent symptoms that are interfering with their life and activities. And then I see a lot of patients who are in for checkups and well child visits who want to talk about headaches while they're there as well. It's a frequent question parents have at checkup time. So it's a frequent topic at the office, very frequent.
And you mentioned headaches causing people to miss school. And so our last podcast, you and I talked about ADHD, and we talked about the impact of ADHD, particularly if untreated, on ability to successfully perform at school. But the emphasis there is at school.
Right.
When someone has a really bad headache, the impact of that disorder is they're not at school. Right. And so that creates a whole different set of problems. So I was wondering how often you find yourself being aware of multiple days a month from school being missed, and what you're asked to do by your patients and your parents to help with that, notes, things like that.
Sure. So I see quite a few patients who have headaches weekly, multiple times weekly, and a lot of those are severe enough to cause school absence, and that's a problem for them. So we do school notes for all those visits, but sometimes to cover days that were missed otherwise. And we often do letters for the school stating that they have recurrent headaches, usually recurrent migraine headaches, and that school absence can be expected. So we try to help. It's hard to put an exact time frame on how often to expect them to have headaches or how much school to excuse in advance, but it's a frequent issue.
There can be certain triggers for headaches at school, just as there are certain triggers for migraine headaches. Smells at school, lights at school, bright lights, dull lights, flashing lights. Smells could be cafeteria food, or if you're in biology class and you get a little frog formaldehyde or something like that. Foods at school. Some kids are foods. Stress and anxiety triggers, right, from that standpoint. Right. So incredibly difficult to predict what the school environment might bring. Fatigue. Right. We know headaches are more common in individuals who aren't sleeping well. And so, that's kind of a problem. But I think sometimes when we talk about, headaches with people and the impact, it's a little bit eye-opening when you start talking about, 2 or 3 headaches a week. We're not talking about a small problem here. Right. And it's one thing to miss school from the headache because you're in too much pain. But part of the problem is then you end up missing a little bit of school just because you need to go get some treatment. Right. And all of that then impacts the parent's ability to be productive because they might not be able to work because their child's at home, or someone else from the family may have to look after them, or the parent needs to go to the appointment with the child. And so then it's affecting the parent's work. And then, it affects the teacher's work from that standpoint as well. But, once they get to you and you think about prescribing them some form of treatment, you're never quite sure how they're going to react to that treatment. Right. So now all of a sudden they might miss a day of school because the treatment leaves them being too sleepy to perform. So they don't have a headache, but they're also not cognitively in an area where they can perform at school. So there are so many ways in which the headache can really cause some challenges with school attendance, extracurricular activity attendance. I know that I've seen some kids before that, they're so disappointed when they get a headache and, it's they miss out on their cheerleading event or playing softball or other things like that, or they can't go to a birthday party. So it's not just an at-school type thing. The headache, until treated, they tend to last for hours and hours and hours, right? And create a lot of difficulty. It's really a very globally health impactful condition because it can affect sleep as well from that standpoint. So we've got a lot of motivation to try and help both the patients and their families with headaches. So can you talk with me a little bit about how you go about figuring out maybe what type of headache somebody has, and then how that leads you into thinking about what type of treatment someone might benefit from. Maybe talk a little bit about some of what we call the old-timey treatments and what we used to do, and then maybe a little bit about where we're at currently.
It is crucial to try to determine what type of headache they have. There's several types. People often, hear about or think about migraine headaches. Migraines are, I think, typically more severe. They often have a visual aura or a visual disturbance patients can realize before the headache occurs. They can feel weak or dizzy prior to the headache happening, so they know it's going to happen. Migraines are often described as being on one side of the head or throbbing. Often can cause nausea. Tension headaches, which are also common in kids and adults, I think are typically a little less frequent, more dull, occur more in the back of the head. Patients can't seem to isolate what part of their head the headache is most severe. Those usually respond well to medicines like ibuprofen, anti-inflammatories. Migraines don't. So that helps us kind of know, too, how to approach it, because if people come in and describe their headaches, they'll often say, we've tried ibuprofen, and that works in the past, but it's not working for this one, or it doesn't work for my headaches. That's kind of a clue that it could be a migraine as well. What we do in the office initially is, for one, get an idea of how often they're happening, and see how they look on exam, how the patients look on exam. Do a good physical exam and a neurologic exam. the way I approach it is if they come into the office and have a normal exam, aside from feeling bad, but a normal neurologic exam, and the headaches aren't frequent, then I would always try first a medication that we can prescribe to help when the headache happens. If it's a migraine, then it would be a medicine aimed at that. Most common treatment now would be something like Imitrex or something in the triptan family. If the headaches occur frequently, and that's subjective. I mean, I'd say if I see a patient who's missing school often, I'd say more than once or twice a month, even if it's interfering with their day often, then I would recommend something they can take daily for prevention, with the goal of not even needing the medicine when they have the headache because they don't have them as much anymore.
Yeah.
Or they're mild enough they can just take ibuprofen to help. There are many medications available for prevention. Initially, they were all medications, to my knowledge, that were developed for other reasons and just shown to help headaches as a pleasant bonus. One was amitriptyline. It's an antidepressant, which was used a lot, I think, in the early days of headache treatment for prevention.
Still
almost before it was used before I was in practice.
Yes.
We didn't use it a lot because it required monitoring. It required EKG monitoring and sometimes blood testing, which on little kids isn't easy to do. And but it was available. We sometimes would use propranolol, also developed for blood pressure. It was very good for headache prevention. It often required multiple times a day dosing to help. And then we would worry about it causing low blood pressure, dizziness, side effects that were undesirable. But it was helpful. We also would sometimes use hydroxyzine, which is an antihistamine for allergies, given at bedtime for headache treatment, for prevention. And I think it was helpful. The only side effect that had that we would often see was drowsiness, which was actually helpful. Help them rest. And with migraine sufferers, ordinarily, if they could get good sleep and rest, they'd wake up and the headache would be way better, if not resolved.
Yes.
But that couldn't be given during the day much if they want to go to school or work. So that's the history, to my knowledge, of how it evolved over time until recently.
Yeah, the propranolol, there's some exercise intolerance there. So you get some people, sports involved, and the propranolol keeps their pulse from getting up. And,
right.
They've got a problem that way. The amitriptyline, as you pointed out, effective and still, fairly frequently today given in fairly low doses. But, a lot of the concern about amitriptyline has to do with its potential for overdose. It can cause a lot of harm that way. So people get concerned about that, looking for other things. And so it seems like today there's a little bit more use of maybe some what are historically or developed as anti-seizure medications.
Yes.
How often do you see that in your practice?
We see some. Those are treatments that I often don't initiate, but I see them after on follow-up visits. Typically, if we see kids in the office that are difficult to control or have severe headaches, very severe, frequent headaches, we have them see a neurologist. So I'll see them back for follow-up to see how they've improved or how they're doing. And I think I see them on Tegretol the most.
Well, Tegretol seems like maybe if people have cluster headaches, which is a more complicated form of headache from that standpoint. And then seems like I've seen some on Topamax, maybe.
Yes, Topamax,
from that standpoint, right?
Yes.
So we got those medicines available. I was touching base on how much time missed from school headaches can cause. And so, gosh, that's even more if they have complicated or difficult headaches, or we don't have medications available necessarily that don't require a specialist. Now, all of a sudden, there's a wait time to get in to see the specialist, which could be quite a while, a couple months potentially.
Yeah, months.
Yeah. And then there's time off to get to see the specialist, and that may not be the only visit because the specialist may want to see him back. So,
or having to get a CT scan for investigation.
Yes, yeah. So time consuming in terms of time away from school. So the more medicine we can get volunteer participants to help us develop in clinical trials that make it easier for you to treat as a primary care doc people at your office and quickly treat them and effectively treat them, then the better. So for sure. Some of the medications, the anti-seizure medications, once again, we're back to kind of the whole point here, which is that, for migraines and or pediatric migraines, it really applies to adults as well as kids. We're using medications off-label that were not FDA approved or were never specifically developed for treatment of migraines or any other type of headaches. And so I've been really excited over the last 10 years for pharmaceutical companies to be doing and developing clinical trials specifically for headaches, and the medications are specifically developed for that indication. Versus us having to do a trial and error process with some other type of medication that they have side effects from that standpoint too. So I'm excited about what clinical trials has to offer in this area. There are medications available to treat different headaches and different migraines. We talk about that, but there was a doc who I trained under who said, Paul, there is, you're never treating a migraine headache, or you're never treating sleep apnea, or you're never treating depression. You're always treating those problems in someone with these types of personality characteristics, who has this type of life and lifestyle, who's inside of this family structure, who has these resources to participate. And so the emphasis there was on everybody needs some individualized effort to treat their headaches. And the headaches can be so impactful. Once again, we're back to one of the things that I really admire about your pediatric clinic is that you got this whole behavioral treatment program available to you. So can you talk a little bit about that again, and what might go on in terms of helping patients and family adapt to dealing with migraines? So.
Sure. We are fortunate to have a couple of child psychologists and therapists that come to our office that we refer to for a variety of mental health concerns, but also to help deal with the pressures or the problems with chronic illness like migraines. And they can often see people in our office and schedule them to see them just for that reason. Or we'll do referrals for providers outside of our office if necessary. I think it helps kids cope with other issues that can occur from having headaches or being sick, like depression or anxiety, which only make the headaches worse.
And they go along with it.
Right.
The what we call comorbidity, which is when you have two illnesses that appear together of migraine, headaches, but also anxiety and depression are there. And one can come before the other or vice versa. And so definitely need to pay attention to the whole mental health of a person, because headaches definitely affect, I think, mental health of a person.
Sure.
David, you haven't shown up for school, 7 times this month, and last month you missed 5 times. I'm beginning to think you're being a little bit lazy.
Right.
And so I want to think that teachers these days are a little bit trained, better trained from that standpoint. But I can guarantee you in some ways when you and I were growing up from that standpoint, that would kind of be the message sent, right?
Sure.
From that standpoint, both to the kid and to the parents. And so how do you cope once again with being viewed negatively for having a medical problem that prevents you from, performing the way that you should? So you get someone on some successful treatment from migraines, and things look different. So what happens, what does it look like when someone comes into your office with a migraine, and what's it look like after you successfully treat them?
When I see kids in the clinic that are having an acute migraine, they look bad. They look very sick. They look almost like they have the flu minus the fever. When I come into the exam room, often the lights are off, the shades are pulled down, the kids are laid out on the exam table with a blanket or their coat over their head, and just look ill. They look acutely ill. They feel terrible.
Yeah, bright light does not make headaches better generally.
Correct.
When you got a bad one. Yeah.
Correct. They often, frankly, have the trash can pulled over next to the exam table because they feel like they're going to be sick or have been. It's great to see them after treatment. If it's successful, they are brighter, happier, back to school, schoolwork improves. Like we discussed with the ADHD on the previous podcast, their self-esteem is better because their school is better, they're happier. I think that helps with any depression and anxiety component as well. And it's great to see that.
Yeah. Socialization improves because their headache is not interfering with their ability to participate in after-school activities or the treatment they took for their headache's gone, but the treatment they took is making them so sedated or groggy that, or the headache, there's a lot of post-headache fatigue cognitively and physically that shows up that they don't want to go participate in their after school activity or recreational activity. And so, or in family activities, it's a birthday party, but, I was in bed. So there's that going on. So much effort. And again, having just come back from the American Academy of Neurology, there's multiple sessions on pediatric headaches and update on pediatric headaches and pediatric migraines and things like that. And the whole goal is, of course, to try and genetically identify what person might be vulnerable to a headache and then tailor specific treatments to what genetics they might have. And there are some treatments they're looking out there as to whether or not we can influence the brain or the body to make more of a certain protein or peptide to prevent the headache from happening. And so a lot of research going on that way at Johns Hopkins and Stanford and things like that that I was excited to hear about. Once again, another thing that I thought I'd never see in my my medical practice time, and yet here it is. And at Preferred Research Partners right now, we're blessed to have the opportunity to do some clinical trials on some pretty exciting medications and a new type of medications that kind of affectionately called the PANTS, PANTS. And so there's atogepant, ubrogepant, rimegepant, all sorts of different PANTs. And these medications are being developed by a number of different companies. And what excites me about them in the clinical trials is, one version of the medicine might treat somebody whose headaches are more infrequent, but they're intense. And so they need to take it at the time that they have the headache, but their headache may only be once every 3 to 4 months. And so they don't necessarily need to be on a medication every single day. And then we've got the preventative medications, which you touched on before, right? And so I was amazed when I started doing clinical trials for headaches and started learning much more about them over the last decade. And I'd look at the inclusion criteria for a study and I'd be like, okay, we're looking for people who have 14 or more headache days a month.
Wow.
And that's what it takes to qualify. And I thought that may be a challenge. Well, no, it's not. And it makes me feel so sad for people and their families if you've got migraine headaches 14 or more days a month to get into the trial. So, and so I'm always hopeful that the medication can help. And some of these PANT medications really do. And what was interesting is these medications have already been studied in adults and FDA approved in adults. And they, the FDA, of course, as you know, has a mandate that clinical trials be done in, little kids and adolescents and teens for the same medicines an adult use. We don't want to make the mistake has been done before to assume that everything's going to work equally effectively or that it's going to have the same side effects or things like that. So the FDA mandates these studies go on in kids. And so we're looking at in the clinical trial medications right now that are effective in preventing the headaches. And so it's kind of interesting. What we're seeing is people may have 14 or more days a month, and they come in and that maybe they come back for their first month or two, and they're saying, well, maybe I've had 3 this last month, because they're keeping diaries and things like that. And I thought, golly, that's really great. And then they come back and maybe they're in month 3 or 4. And I look down and I'm like, well, is the medication causing you problems? No problems whatsoever. Okay, well, you haven't taken any in the last month. No, I haven't. I haven't needed to. So some of these PANT medications we're looking at, it wasn't the intended effect of the medicine. The effect was to prevent them from happening, but some would break through. But we're discovering both in adults and kids that it actually is reducing and in some ways preventing the migraine from ever occurring. And I never thought we'd get to that point from that standpoint. So that's going to be pretty cool. And so with us working on this clinical trial, the hope is medication gets FDA approved. It becomes something you can incorporate into your practice. And so then you're going to see some smiling faces for both your kids and parents, right?
That's exciting
from that standpoint. Yeah. So I know that's why you're, interested in working clinical trials. You and I share this passion toward, trying to help people and recover from a variety of different medical conditions from that standpoint. And nothing makes us happier in our heart, right? To see somebody that has had a major turnaround in their how they feel and how they're doing, and particularly in kids, we got a warm spot there. So excited about some of these clinical trials we've got coming up for sure. I was wondering, you I think have seen more severe headaches than I have. I mean, really severe. And so I know you mentioned that you refer them to the pediatric neurologist, which is the children's hospital, right? But
yes.
How often have you had to maybe send people to the hospital, and what happens when that occurs, when it's that bad?
So I don't have to from my office very often, because I think those people go to the hospital initially. Okay. I see a lot of them for follow-up after an emergency room visit. Where they sometimes get even IV medication for the headache. Yeah,
I was going to ask what happens when they're at the hospital. So.
Yeah, I think they get IV fluid hydration and IV medication for the headache.
Okay. And
then they come to see me in the office for follow-up, or I guess both, to make sure they're better and to see if they need anything going forward for prevention or treatment.
Okay.
So we don't send them to the ER from the office often, because they're usually already at the ER.
Already there. Okay, so you're seeing them after. And then when they get to the ER, the pediatric neurologist, and I don't know if you're ordering it in your practice, how often are maybe scans or other sort of imaging tests being done?
I think if they require an ER visit, they're done pretty frequently.
Okay.
From our office, I would order a CT scan if the headaches are not responding to treatment, or if their neurologic exam is abnormal. So I do order some, not very frequently, but I order some. But in the ERs, they're frequent. I think the docs there feel if it's enough to merit an ER trip, and the kids look acutely sick, then they often get a CT scan.
Yeah. And sadly, some of those scans are positive for some other things going on, right?
Right.
Yeah, from that standpoint.
Yes. I think the motivation is to not miss anything else, like a brain tumor or aneurysm that could mimic a migraine.
Yeah. I'm thinking like intracranial hydrocephalus,
right?
Stuff like that.
Right.
Yeah, from that standpoint. So as docs, we're always very concerned about, are we missing something that's far worse, right? From that standpoint. And it can be really troublesome to think, okay, well, I've been working with this person for 2 months trying to figure out what treatment they're using and what might help for them, and nothing's working. And, they might have a bigger problem from that standpoint. Yeah. Going on. So
I always tell the parents, let's try this. It's kind of our first initial plan to try this first, whatever it might be. But if things get worse, or if this is not working, then let us know, because that's when we would consider doing a scan or a referral for neurology.
Yeah. Yeah, I want to encourage parents not to be discouraged if they go to a physician's office and what the physician tries first or second isn't working, that somehow, well, that doc, he or she or whatever, really doesn't know what they're doing or whatever.
Right.
I need to go see somebody else.
Mm-hmm.
And don't make that assumption. Go back and see the doc and say, hey, this isn't working, because the doc's going to say, oh, okay, now, we got to take a look at different things from that standpoint for sure. Yeah. And we touched on it earlier, but how often do you think you're seeing headaches comorbid with other types of conditions that you treat, where you end up having to manage both from that standpoint?
Now,
It could be anxiety, depression, but it could be other like medical conditions that you're seeing. For example, POTS has been more frequent since COVID, things like that. How often are you dealing with headaches and they pop up as part of a secondary problem when someone's coming in for another primary condition?
I think it's fairly common, probably more so in adults. But we see some in kids. I see headaches along with our patients who have type 1 diabetes, for example. If their blood sugar control isn't good, that's a frequent symptom. We see it some with kids with hypertension or high blood pressure, but that's luckily not as frequent in kids as it is in adults. If they have that, we would worry there's something that's making that happen that we would investigate. I'd say we see it probably most often along with anxiety and depression. And that's fairly frequent.
Okay. I think we've had an excellent discussion today about headaches and giving people kind of a view into how they might be managed in a pediatric practice and what sort of things we as docs get concerned about, and talked about some of the medications that are out there and maybe some of the exciting new developments that are part of the motivation for you and I to be spending our time performing clinical trials. It's always nice to kind of look out for people in the future, right? I always feel like with clinical trials that I can make, maybe, if I help develop the medication, a really big impact on a lot of people, even outside the clinical practice from that standpoint. So if I can leave my practice at some point with that, or leave being a physician at some point with that, I think inside be pretty happy. That would have been a goal, and I'm sure you feel the same way. Yeah,
I do.
So again, thank you for your interest and participation and being an investigator with us.
Yes.
And for working with preferred research partners. So,
well, thank you for having me. I'm excited about the being on the team and the invitation for the podcast.
Yeah, you bet. Well, folks, thanks again for tuning into this episode of Hope in the Pipeline. As always, please like, rate, and review our podcast, which helps more people to find it and to learn from it. If you know someone who you think might benefit from viewing this podcast episode, please share it with them. As always, thanks so much for listening to today's Hope in the Pipeline, and we'll see you again next time.